So hi everyone, my name's Aaminah Verity. I'm the PCN lead for health inequalities at North Lewisham Primary Care Network. I'm really sorry I couldn't be there today in person to share our work with you, but I'm going to take you through our approach to health inequalities in our primary care network. So for those of you that don't know, North Lewisham is in a vibrant area. Our primary care network represents 9 GP surgeries of 80,000 patients, but unfortunately we have high levels of socioeconomic deprivation, a high proportion of non-white residents, and some poor health outcomes associated with that. We did some community engagement back in October 2020 to try and understand why health inequalities were perpetuated in North Lewisham, and 32 community organisations fed into our stakeholder engagement. And we settled on 3 key themes, which were a lack of trust, barriers to care, and the social determinants of health, which we've called poverty here. We started working with those community organisations and other stakeholders and individuals to start designing solutions and ideas from the community. Initially, we focused on improving COVID-19 vaccine uptake, and we collaborated with community organisations to put on COVID vaccine pop-up events, which were run by the community organisations, and they did their own engagement strategy. We've been co-designing solutions to improving access to GP care, including a digital hub where our care coordinators can help people who are digitally excluded, improving messaging around how GP access has changed, and signposting patients to different support organisations before coming to the GP. We've also hired a community link worker. We were really lucky to find Joyce Jacker. She's a local resident who's got 25 years of experience of working with the community locally, and she's now the face of our primary care network, providing a link between the community and the GP surgeries. And she's helped us set up the North Lewisham Community Forum, and this is a space where we meet every 2 months in rotating community venues across North Lewisham, and we always pay for food. We do a hybrid model where it's online and in person. We always make sure we have a visual minutes artist to capture the discussions that were happening. And the really key thing about this is that because we meet regularly, we're constantly providing feedback to the community about what we're doing, how we're working together, and keeping that engagement going. I'm going to take you through now our data strategy, which started with the question of how do we identify people who are at risk of health inequalities as frontline staff. And we identified 300 codes that we thought put people at the highest risk of health inequalities. And these are codes that represent most inclusion health groups, things like a person experiencing homelessness, drug addiction, safeguarding referrals, vulnerable migrants. And what happens is that if any one of those codes exists on a patient's records, EMIS throws up this automatic pop-up that says possible health inequalities, and the clinician is triggered to double click on that link. It then shows you why the code has fired and prompts you to then recode other vulnerabilities. And then we provide a clinical and administrative guidance around this to help make sure that every contact counts for these patients so that they don't get lost in the system. And I'm going to take you through an example of proactive screening that we've done using this population health tool. So we did a really small scale pilot of 70 patients over 18 who hadn't had a blood pressure reading in the last 5 years and had one of these codes, and we invited them for a health check. And what we found was that 60% had some abnormality with, significant things you can see in the bottom right graph: pre-diabetes, risk of diabetes, overweight, high blood pressure, and 40% of them were under 40, showing us that, that adage, you get sicker for longer, as health to be impacted by health inequalities. So we're now rolling that out across the PCN in a pilot, looking at inviting people for the NHS health check. So this is 40 to 74. And we've only got a small amount of the data available at the moment because the pilot is still underway. But you can see, compared to the national average of 9% of health checks picking up someone at risk of high risk of cardiovascular disease, our health checks are finding, patients with high Q risk scores, raised blood pressures, people who are overweight and pre-diabetic. We've worked with the population health team to add in socioeconomic deprivation and ethnicity to that as well. So just to summarise, our model for health inequalities is community-led, it's collaborative, working with the population health team, public health and council partners. It's prioritised by the PCN, which means that any new initiatives within our primary care network has a focus on health inequalities. But most importantly, it's resourced, and I've been paid in this role as primary care network lead for health inequality since October 2020. And I think that's a really important message, that if you resource people properly to do this work, there is passion and excitement around coming up with innovative solutions around this. And this is now being replicated in the autumn by Public Health and the CCG in Lewisham, so that there will be a PCN fellow lead for health inequalities for every single PCN in Lewisham. So I'd like to acknowledge these people who've all been part of various stages of the work. And again, I'm really sorry I can't be there, but hopefully the slides will be available to share. My email address is on there, so please feel free to contact me. Thank you for listening.